advancing medical education, awareness in continence care, and also functional urology across this region. We're absolutely delighted to have outstanding regional faculty from Thailand, Vietnam, Malaysia, and Korea joining us this evening. Tonight, we have over 150 participants joining online across APAC region. We've put together the program because nocturia remains surprisingly under-recognized in our daily practice, despite its rather substantial impact on sleep, falls, cognition, quality of life, and healthy aging population right now. So we begin by exploring the epidemiology, the burden of nocturia in APAC, followed by the real-world diagnostic barriers, the pitfalls of bladder-centric thinking, and finally, the important relationship between nocturia and sleep fragmentation. We'll then move into what I suspect will be the highlight of this evening, an MDT case discussion focused on real-world clinical practice pitfalls and practical management approaches. Before we begin, just a few quick housekeeping points. You see the QR code on the screen at the end of the event. We'd be very grateful if you could scan it for attendance and feedback purposes. And please do feel free to submit your questions into the chat box throughout the session. We'll collect them as we go and trying to address as many as possible during the panel discussion final Q&A. Specializes in urology, urinary incontinence, and pelvic floor construction, with fellowship training in Innsbruck Medical University in Austria. He currently serves as the president of the Thai Continence Society and held several leadership roles within the Thai Urological Association. This evening, he will give us a talk on the hidden epidemic burden of nocturia and nocturnal polyuria in APAC region. Please join me in welcoming Dr. Sontide. Dr. Sontide, over to you.
Okay, thank you, Dr. Mark. And good evening, honored colleagues, friends, and everyone in this room and also in the online Zoom. I just know from the Dr. Mark about it. Now we have a participant more than 100. It's quite good, very great, and make me a little bit nervous something about quite a lot of the participants today. Okay, so before I start off my talking, may I say hello to my old friend from Malaysia, Dr. Warren. Hope you fine, okay? And also new friends from Korea, Vietnam. I'm really pleasure to warmly welcome everyone to join us for Thai Continence Society with the foreign company. I think it's like a kind of the international small group talking, especially in the nocturia for today. I hope we will exchange knowledge and experience, also having a vulnerable moment, collaboration between us. Okay, so my topic is about the hidden epidemic burden of nocturia, nocturnal polyuria in APAC. The prevalence of the nocturia have been recorded about 1/4 in men and about 1/3 in women from study around the world. And also in my country, Thailand, we have a study from the Ramathibodi University Hospital. They did the study in the women who have the menopause, and we found the number of this group have the nocturia about 40%. It looks like the prevalence is in Thai women higher than the normal average around the world. And if we conclude the study in this graph, you will see the nocturia is always increasing with age in both group, men and women. And also, if we looking in the number of the nocturia, it's always increasing with rate on age also. Why? Why nocturia is important? Because nocturia has a negative impact for health, quality of life, productivity, and sleep pattern. Inadequate treatment of nocturia. Basically, the patient who have nocturia, they will live this issue with themselves around a year before they decide to see the doctor or consult to their physicians. And also the report showed the patient will take about 2 years for getting the proper or the right treatment. Why? Because they always treated nocturia by focusing in the OAB, in the BPH, and always ignore to the true nocturnal polyuria. And what happened when the nocturia is untreated? They will have the low sleep quality, and then it will affect to their energy, healthy, problem about the quality of life, and loss of the productivity on their work. And most of the elderly patients who have the nocturia, how much that he have to wake up 4 p.m. is we have more risk of the falling, fracture every time. Actually, the OAB, BPH, and nocturnal polyuria may be possible to overlap in some issues, but the pathophysiology is always totally different. I think we all know about the overactive bladder. It's just a kind of the involuntary contraction of the bladder by idiopathic or neurogenic cause. It depends. And also about the BPH, it just because of the bladder outlet obstruction. And nocturnal polyuria, it just impair of the secretion of the arginine vasopressin. Then it will reduce the ability of the kidney to concentrate the urine. Definition of the nocturnal polyuria, you will have two definitions. First, you may use the nocturnal polyuria index by cut point of the urine nighttime more than 30% of the 24-hour urine output. Or you may use the definition by the nighttime urine output more than 90 ml per hour. From the previous slide, I have already showed about the nocturnal symptom. It's always overlapped in the OAB, BPH, and nocturnal polyuria. But the study showed nocturnal polyuria is the main cause of the nocturia. It's just about 80% of the nocturia, about the 80% of nocturia caused by nocturnal polyuria. And if you're looking in the overlap with the overactive bladder, we will see number about nearly 60% that overlap with the overactive bladder and nocturnal polyuria. And also about 60% overlap with the BPH and nocturnal polyuria. That's why sometimes the doctor treat the nocturia by focusing in the overactive bladder or the BPH. Sometimes it didn't work well enough for the patient who have the nocturia because Like I told you, most of the nocturia actually caused by the nocturnal polyuria. The quality of life is related to the quality of sleep pattern. That means about 50% of the nocturia patients dissatisfied in their sleep pattern. You will see about nearly 40% increase with the sleep disturbance score. About 10% they will have the short sleeper, and about 60% they will get like a sometimes when patient wake up for urination during the nighttime, about 60% that they always get the problem to fall asleep again after they wake up for urination during the nighttime. And also, it's nearly an hour to back to sleep again after they woke up during the nighttime. And in my opinion, I think the serious issue for the elderly patient have a higher risk of the falling and fracture, and also they will have to increase the mortality risk. When the patient have the nocturia more than 3 times, it shows that they will have more risk of the falling and fracture. The study show about 28% possible to get the falling with fracture. Not just the nighttime falling. In this 28% is the overtime, because whenever the patient and the elderly patient have to wake up during the night, they will have the lost energy, fatigue on the daytime. Some case have the dizziness, and it's quite easy to falling and fracture on the daytime also. And they need, after falling and fracture, this group have to stay in the hospital. Some cases need to do the operation or surgery. You will see about the cost of this treatment is more than about 1.5 billion. It's very high. And furthermore, not just cost the treatment, they will have more risk of the mortality, because the falling in the elderly patient will make the patient have the immobilization for a while. Some cases have to do the operation, need to stay longer, and then to be a cause of the infection, and very easy to get the sepsis, especially in the elderly patient. Also, it's very significant in risk of the falling and fracture when the patient have to get up during the nighttime. That means how many times that he have to walk up for urination, that's always have more risk. Like in this graph, you will see the blue color. It just wake up for one time urination compared to the gray color. It just more than 2 times for urination during the nighttime. The number of the falling fracture and risk of mortality is way higher significantly about the 1 time and more than 1 time during the for nocturnal waking during the nighttime. Several studies showed poor sleep quality, increased mortality risk, and have life expectancy lower. This study, they used the 5 low-risk sleep-related factors by defined by one's sleep duration, 8 hours per day, difficult falling asleep less than 2 times per week, trouble staying asleep less than 2 times a week. Third, no sleep medication using. And the last, waking feeling rate more than 5 days a week. That means whenever they have a high score, That means they will have a very good sleep. And the results show the group who have the high score, have a good sleep, they will have a good health, good quality of life. And also they will have a high life expectancy, both in men and women. So in my opinion, nocturnal treatment is not just reduce the nighttime voiding or urine volume, but the important is we are going to make the patient have a good health, good quality of life. Also, they will have a good sleep. This slide I just want to show you about the nocturia brochure in Thai version by Thai Continent Society. The main, we just want everyone to understand and about the nocturia and etiology and how to diagnose by the bladder diary for the getting the right treatment later. Okay, thank you.
Well, thank you so much, Dr. Sontidet. I think one particularly important point here is that nocturia is often dismissed as a simple part of aging, right? Whereas in reality, the consequences is quite significant, particularly sleep disruption and also falls as well. So then we get moving on to the next speaker. Our next speaker is Associate Professor Le Din Khan from Vietnam. Professor Khan currently serves as the Vice President of the Hue University Medicine and Pharmacy Hospital, head of the Department of Urology Surgery, and he's also the President of the Vietnamese Urology and Nephrology Association. He published extensively regional and international journals, and his international training include advanced urology and urodynamic training in German and Belgium. Tonight, he will be discussing diagnosed barrier from bladder diary, real-world evidence from Vietnam. Please join me in welcoming Professor Khan. Professor Khan, the floor is yours.
Good evening, ladies and gentlemen. Can you help me?
Yes, we can hear you very well.
Hello?
Yes. We can very well. Do you mind projecting the slide from your end?
Yeah, okay.
Thank you.
First of all, I would like to thank you so much to organizer and touring company to allow me to attend this workshop. And it was a pleasure meeting you all and sharing some of my experience in the field of nocturia. First presentation, I would like to talk about diagnostic barrier from bladder diary, real work evidence from Vietnam. This report is based on the finding of a study conducted at our hospital. Nocturia in BPH patient account for 70 to 90%. This is strongly associated with an increased risk of accident, particularly fall and fracture, as well as daytime fatigue, depression, and especially poor quality of life. And there are two kinds of polyuria, global and nocturia. Nocturnal polyuria is diagnosed by definition when the ratio of nocturnal urine volume to 24-hour urine volume is over 33% for patient over 65 years old and over 20% for patient under 65 years old. And is it necessary to differentiate between nocturia with or without nocturia? However, in clinical practice in our hospital, diagnosis of nocturia is easy, but diagnosis of nocturnal polyuria is not easy. To understand the difficulty involved to performing bladder diary, we conduct a study on nocturia in patients with BPH to investigate the challenge in clinical practice when diagnosing nocturnal polyuria at the University of Medicine and Pharmacy Hospital. We realized on the study on 114 patients diagnosed with the BPH. And we communicate and talk with the patient and diagnose nocturia based on the ICS definition of nocturia. And we did also the laboratory test, for example, ultrasound for assessment of the prostate volume, measurement of residual urine volume, PSA test, and did also uroflowmetry. The patient was instructed to complete a bladder diary at home. From our study, results show that we have on 114 patients, there was 86 patients have nocturia, accounted for 75%. And nocturia affected the patient's quality of life. The majority of patients have missed quality of life. And unfortunately, there are only here in our study only 34 patients account for 30% who was able to complete the bladder diary, fairly low percentage. And in these patients of the patient who could complete the bladder diary, only 16 patients account for 47% had nocturnal polyuria. And regarding the reason for inability to complete the bladder diary, non-cooperation accounts for 68%, or age unable to do bladder diary independently accounted for 25%, and other zero reason accounted for 6%. We have in our study, there was 2/3 of a patient with BPH have a symptom of nocturia. This is consistent with the result in other study published in literature, accounted for 70 to 90%. And nocturia can be classified according to its four main causes: 24-hour polyuria, bladder storage disorders such as OAB or BPH, nocturnal polyuria, and various related factors including OAB and nocturnal polyuria. Nocturnal polyuria is considered one of the main causes of nocturia, and is associated with the decreased secretion of antidiuretic hormone arginine vasopressin, and it causes the significant proportion of nocturia cases, with a prevalence often reported between 67% and 80% among those affected. However, in our study, the results show that only for 47.1% nocturnal polyuria, this is a fairly high percentage. But this result is not consistent with the result of other study. But here we only want to present this result for reference. Our research results are lower than those that have been published in literature, and we are not yet clear why this rate is low. Perhaps we need to expand the number of patients and conduct a study in more center. Regarding diagnosis of nocturnal polyuria, diagnosing nocturia is not difficult, but in fact, in our hospital, diagnosing nocturnal polyuria in patients with BPH not easy. The biggest obstacle is the inability to complete bladder diary. In fact, only in our study, only 1/3 the patient can complete the bladder diary, which could help diagnose nocturnal polyuria. More than half are uncooperative to for various reasons, with the majority finding it inconvenient to do so. And this is the most common reason. The majority of BPH patients are elderly, so completing bladder diary is a major obstacle. In addition, other reasons such as living condition, cramped living space, etc., are also obstacle. With this small study, we would like to share some our thought in Vietnam. Are there any solutions to replace the bladder array in the diagnosis of nocturnal polyuria in Vietnam? For example, could an automated device measuring the number of urination in urine volume be linked to patient's phone? We know now that there are currently some tools in the world that can help complete the bladder relatively simply. However, there's not yet availability in Vietnam. In future, we think if a device that can connect to phone for automatic measurement will be completing the bladder similar, and until then we can easier monitor the patient and diagnose the nocturnal polyuria. And second, good decimal dressing treatment be effective for all patients with nocturia. And we believe that the prescribing medication without precise diagnosis is inappropriate. We hope that in the future there will be better solution to help patient completing the bladder diary. However, currently the use of decimal dressing in treatment nocturia is providing effect. We need consider this future, and furthermore, I will present a clinical case to clarify this point. Thank you so much for your attention.
Thank you so much, Professor Khan. I really endeavor, the effort from your team, and thank you so much for sharing, such an invaluable information with us. I think bladder diary sounds simple in theory, right? But in real life, it can be surprisingly difficult, for the patient to complete the diary. Okay, let's move on to the next session. It's now a pleasure to introduce Dr. Warren Low from Malaysia. Dr. Warren Low, he is a leading Malaysian urologist specializing training in neuro reconstruction urology, female urology, and functional bladder disorders. He's notably the only urologist in Malaysia performing sacral neuromodulation procedures for bladder dysfunction and also European certified robotic surgery. In addition to his clinical work, he remains actively involved in clinical research and postgrad urological education. In this evening, Dr. Warren Low has already dialed in from China, and he will discuss under the topic, when lots meet leads, why nocturnal polyuria is often missed. Warren, over to you. Thanks. Over to you. Yeah, you can project your slide from your end.
Right. Okay. Can you hear me, Mark?
Yes, I can hear you. I can hear you very well.
You can see my slide.
I think it's about. It's about projecting.
Okay, can you see my slides?
Okay, we can see your slide now, so you may
Okay,
get started.
perhaps let me just readjust a little bit, okay? Just give me a second. Sorry for holding everybody back. Just give me a second because I'm trying to share something.
No worry at all. Yeah,
Okay.
it's good to have a break from to previous bombarding knowledge to everyone.
Okay, so can you see my slides now?
We're about to see yours. Yes, please get started. Cheers. Warren. It seemed like it's
Right.
it's like frozen from your
Thank you,
side.
Mark, for the kind introduction. So I'm Warren Low from Malaysia. This one is when lower urinary tract symptom misleads. Is that so? Can you hear me now?
Yes, we can hear you. Please keep going on.
Can you hear me?
Yeah, I can hear you. We can hear you, and we can see you advancing the slides as well. It's because I think Chinese in the internet.
Okay. All right. I think that in my hotel, it's probably a little bit in terms of the net. My topic actually have two components. First is lower urinary tract symptoms. Lower urinary symptoms. Second one is why you must understand lower urinary is actually a class of disease. So sometimes can actually mislead the clinician into assuming that the BPH, the rectum bladder, the prostatitis or UTI, all these things may actually be mimicking something like a lower urinary tract infection or lower urinary tract symptoms, but in actual can you hear me?
But it's an advancing slide because we
Can you
cannot.
hear me?
I can't see you advance the slide.
Can you?
Maybe you turn off your camera, perhaps. It would be better to save the bandwidth.
Can you hear me now?
Yes, I can hear you. But your picture still being frozen.
Yeah.
Okay, can you turn off your camera to save the bandwidth and then just project the slide? Sorry from our technical problems. We were trying to resume the meeting as soon as we can. Welcome back, everyone. So For a technical internet connection, because Dr. Warren dialed in from China, maybe the Chinese, internet they banned. But my sincerely apologies, for the hiccup. Yeah. So we will move on to another session. Yeah. Um, so our next speaker will join us from Korea. As I said, Professor Hyun Woo Kim. Professor Kim is a faculty member in the Department of Urology, Busan National University College of Medicine, and currently serves as a Director of Research for Korean Continent Society. His background combines clinical urology and biomedical engineering and translational sciences as well. He holds a doctoral degree from both engineering and medicine. His research interests include lower tract dysfunction, aging, and sleep-related urology. So this evening, he'll discuss sleep first, nocturia as a driver of sleep fragmentation. Please join me in welcoming Professor Kim. Professor Kim, over to you.
네, 여보세요? 제 차인가요? 아, 죄송합니다. 네네네. 이제 아, can you hear me?
Hi, Dr. Kim. Yeah, we can hear you very
Yeah,
well.
can you? Okay.
Yeah.
I'm sorry. I just had some lag. So,
No
okay,
worry
I'll
at all.
share my slides with
Yeah,
you.
please project your slide from your end.
So may I start now? Okay, I think you all see my slide right now. So I'll start with my presentation. Okay, good evening, everyone. My name is Hyun Kim from Busan National University School of Medicine. I live in Busan, Korea. It is a great honor to participate in this webinar, and I really want to appreciate the organizers of this webinar and Fering. And today I'd like to discuss about how nocturia acts as a primary driver of sleep fragmentation and why restoring sleep should be our top priority in management. Okay. Okay, I'll start with the definition. According to the ICS 2018 update, nocturia is defined as walking to pass urine during the main sleep period. There are three key elements here. First, the void must be preceded by sleep, followed by an intention to return to sleep, and third, it must occur during the main sleep period. So clinically, we must quantify this using a validated 3-day bladder diary. The important thing is that patients typically find the condition bothersome once they reach 2 or more voids per night. Nocturia is one of the most common medical symptoms across all aging populations. And as you can see from these graphs, the prevalence increases significantly with the age. While younger women tend to report more nocturia than younger men, by the time patients reach their 60s and 70s, nearly 80 to 90% of both genders experience at least one void per night, with a high percentage experiencing 2 or more. So how about Korea? Looking specifically at the Korean population, a national survey of over 2,000 subjects revealed that nocturia is remarkably prevalent. Nearly half, actually, for exactly 48.2%, reported voiding twice or more per night. The data shows a clear upward trajectory as patients age, confirming that this is a major public health concern in Korea, impacting both genders significantly. So, and in a large-scale study across the US, UK, and Sweden, nocturia was identified as the most prevalent of all lower urinary tract symptoms. Whether we look at voiding symptoms like weak stream or storage symptoms like urgency, nocturia consistently ranks at the top. This underscores that while we often focus on flow or urgency, nocturia is the symptom most patients are actually living with every night. Interestingly, nocturia is often more bothersome than daytime lower urinary tract symptoms. Real-life patient data from Europe and the US shows that patients with nocturia report a significantly higher impact on their quality of life compared to those with daytime symptoms only. The underlying reasons for this bother isn't just the act of urination, it's the sleep disruption that follows. It is essential that nocturia is understood, treated, and monitored as a distinct problem from OAB and BPH to ensure that patients are treated for their main symptom. We must also recognize that nocturia is a marker for pro-systemic health. It is strongly associated with cardiovascular disease, diabetes, obesity, and depression. In women, it correlates with inflammatory conditions and menopausal status, while in men, it's linked to prostate health. When a patient reports two or more voids, they are statistically more likely to rate their overall health as poor. So now let's look about the sleep fragmentation. This you can see this figure. This is a hypnogram. This hypnogram illustrates sleep fragmentation, and a nocturnal void resets the 90 to 120 minute sleep cycle. This conscious arousal prevents the patient from reaching stage N3 or deep restorative sleep. This fragmentation severely impairs neural recovery and the clearance of metabolic waste from the brain, increasing what we call sleep pressure or homeostatic load. According to research in 2008, urination is the single most common cause of sleep fragmentation across all age groups. For those aged 65 or older, it far outweighs pain, noise, or breathing difficulties. This makes nocturia the leading disruptor of restorative rest in the elderly population. The consequences are very clear. As you can see in this graph, the 52% of patients with nocturia are dissatisfied with their sleep patterns. On average, it takes 49 minutes to fall back to sleep after a nocturnal void. This isn't just a 5-minute trip to the bathroom, it is an hour-long disruption that results in short sleep duration and high sleep disturbance scores. Poor sleep quality bleeds into the next day. The patients experience a reduced capacity to work, an inability to focus, and a significant lack of energy. About 60% of these patients reporting being always or usually tired. The urological system has become daytime functional impairment. The economic impact is also substantial. Nocturia impairs work productivity and daily activities to a degree comparable to other chronic diseases like asthma or depression. We are looking at a 14 to 39% overwork impairment, driven largely by fatigue, which is caused by nocturia. Perhaps most concerning is the link to mortality. Data from reduced study shows that men voiding 3 or more times per night had a 72% higher risk of mortality. When sleep disturbance was added to the model, to this statistical model, the association was weakened, suggesting that it is the broken sleep caused by nocturia that primarily drives this increased mortality risk. But we always have the management. The good news is that treating the underlying cause, such as nocturnal polyuria, actually works. In studies using low-dose desmopressin, we see significant improvements not just in number of voids, but in the IPSS QoL scores and the Athens Insomnia Scale. By reducing the urine volume at night, we are directly improving sleep maintenance. Before we conclude this presentation, we must understand that the bidirectional relationships. Insomnia increases bladder sensitivity, and conditions like sleep apnea trigger nocturnal polyuria through AMP release. So these are my take-home messages. The take-home messages are: manage nocturia as a distinct pathology, and prioritize sleep restoration to improve daytime productivity and long-term health, and also use a multidisciplinary approach to address comorbidities. Thank you for your attention. Okay, this is the end of my presentation. Thank you.
Hi, Dr. Kim. Thank you so much for your excellent talk. I think the most important thing that you highlighted is about the consequences of, sleep fragmentation, which may lead to, untoward consequences that we don't want, cardiovascular outcome, yeah, and desmopressin could potentially help improve the quality of life. Thank you so much. So then we will, move back to the session of Dr. Warren Low. Yeah. Dr. Warren, are you on the line?
Yes, I am. Can you hear me?
Okay, I can hear you very well. Yeah, as long as Chinese government allow us to project the internet from your side.
Okay, so the thing is that can you see my video? Can you see the slides?
Yeah, I can see your face right now.
You can see the face?
Yeah, face and slide, perfect.
Okay, let me just try it out and see. Just allow me to just adjust my slides a little bit, if you don't mind.
Yes.
Okay, sorry,
Okay,
Dr. Warren.
can you see my slide now?
Yes, I can see your slide now, but it's not in the. Okay, right now it's perfect.
Right.
Cheers. All right.
All right. I think there's a little bit of a lapse of time.
All right. Perfect. Cheers. Please get started.
Okay, so I will just repeat again in a very quick way. The topic that was given to me basically have two components. The first one is when LUTS misleads, and the second one is why nocturnal polyuria is often missed. Now, we know that lower urinary tract symptoms are basically not the diagnosis. It's a symptom complex. Itself is actually not a disease, but sometimes it may lead us into assuming that the BPH, the overactive bladder, the prostatitis, and UTI, all these things may actually mimic lower urinary tract symptoms, but other things such as cardiogenic cause, renal cause, for example, an element of nocturnal polyuria could be very well behind it without us knowing. Now, when it comes to LUTS, we know that the ICS actually has divided into 3 phases. When it comes to a symptom phase, what are the symptom phase? Basically, you look at this, the first storage phase is a filling phase. Encompasses increased daytime frequency, nocturia, which is an important part of it, urgency, urge incontinence, stress incontinence, mixed urinary incontinence, and bladder sensation, whether there is an increase or reduced bladder sensation. Then we move on to the next one, which is actually the voiding symptoms. So often we hear people talking about slow stream, intermittency, straining to void, playing, splitting, and all. So this is the second one. And the third one is the symptoms after maturation. Sometimes they may experience post-maturation dribble or feeling of incomplete emptying the bladder. Now, when patients present to us with lower urinary tract symptoms, as I mentioned earlier on, especially when it comes to men, often being mistakenly as having the BPH. Because when we just look at the patient complaining to you, telling me that, like for example, going to the toilet like 3-4 times a night, it may automatically ring a bell thinking that he may have prostate enlargement. But the truth is that if you were to look at him, the whole body, you will probably see some pseudoedema. And also at the same time, you can see that he may have some generalized swelling. Maybe he's a chronic kidney disease patient. And if you were to probe the history further, you may actually find out he also have heart failure on certain diuretics. So all these things basically will pinpoint to you what is the actual symptoms that he has and that will clinch the diagnosis. Now, and when it comes to women, a lot of them have overactive bladder, we understand. So when the patient presents to you with frequency, urgency, straight away, we think that they have overactive bladder and treat them with antimuscarinic or even beta-3 agonist or even Botox. But you must understand, this may not be overactive bladder. It could be bladder carcinoma in situ, maybe even urinary tract infection, maybe even radiation cystitis or even ketamine cystitis or not. But you got to really find out. A lot of us do not ask the history in detail. Now, when nothing fits the basket or fits the bill, like for example, patients say that a bit of frequency, a little bit of pain over there, and in men, when they have a bit of ejaculatory discomfort, straight away, we put them under the category of prostatitis because it is like a no man's land. But you must understand, when you label the patient as having prostatitis, you also need to rule out a lot of other things because the patient could be having urethral stricture, bladder stones, or maybe even a pelvic floor dysfunction that actually makes the patient present like that. So this is actually a part of a lower urinary tract symptom as well. Women who are often being treated because of the UTI, given multiple antibiotics and never seems to recover, you really have to think hard whether she is genuinely having urinary tract infection, because for postmenopausal women, they could be having an atrophic vaginitis or even urethritis. Or for some patients who actually have a chronic pelvic pain syndrome, they could be having an interstitial cystitis. So do not unnecessarily treat the patient with antibiotic, especially when you're not too sure whether this is a genuine UTI or not. Young men often come to us, you know, that they are only probably about 30 to 40 years old, having all these lower urinary tract symptoms. You would have thought that, okay, this is a man, I may be wanting to start him with some prostate medication, but you know that this group of people will not have a big prostate. So in that case, probe further, find out whether he has a bladder neck obstruction, high bladder neck. He may even have a detrusor underactivity that present to you with overactive bladder. The reason is because when you're not able to empty the bladder, there's a substantial amount of urine inside the bladder and you go on drinking, make the bladder overfill, the patient will naturally present to you with an overactive bladder-like symptom. In actual fact, he is having an underactive bladder. And of course, we do know that when patient tells you, I have poor stream, I can't empty my bladder properly, I feel that something is obstructing down there, you would have thought that, okay, maybe bladder stone, prostate disease, or even urethral stricture, but you also often miss out another important entity, which is the bladder. Patient could be having a diabetic cystopathy, patient could be having a neurogenic bladder, such as those who suffer from Parkinson's disease or spinal cord injury or spinal disease. They may actually present with underactive bladder, but all that they can complain to you is that they have very, very slow flow or unable to pass urine properly. Now, we must understand that the moment we sleep, something will come out. That is our hormone. We call it as vasopressin or antidiuretic hormone. And that only presents to us when we sleep. Then it will actually concentrate our urine to become 1/3 of the daytime. Problem is that there are a lot of us who actually cannot sleep, those who suffer from insomnia. So when you're not able to sleep, the vasopressin hormone is not coming out. Naturally, the urine is not getting less. So you pass urine just the same as the daytime. That's why you present to me with a lot of nocturnal polyuria or even nocturia. Now, there are some patients who have obstructed sleep apnea. In this kind of patient, they often have a negative intrathoracic pressure. And in other words, they also will have an increased AMP release or atrial natriuretic peptide release. And this will further worsen the night urination. So sometimes we think that, okay, just because he goes to the toilet too many times, that's why he can't sleep. But you must understand that sometimes it's because of the sleep deprivation that results in all this nocturnal polyuria or nocturia. Most of us don't actually find out in detail about the history of medication, especially when you probe further, you realize that they are actually on maybe some diuretics or calcium channel blocker. All these things can cause diuresis. And those patients who are actually on antidepressants or even sleeping pills, they basically will present to you with underactive bladder. That's the other element of it. So if you were to probe the history further, knowing a bit more detail about the medication, you will find out exactly what causes all these lower urinary tract symptoms. As I mentioned to you earlier on, a lot of us having neurological issues such as multiple system atrophy, Parkinson, Alzheimer's disease, stroke, but we don't actually realize why we are passing urine so much, because all these things can give you a lot of overactive bladder-like symptom, and yet you are not able to empty your bladder. So naturally, it clinched the diagnosis of lower urinary tract symptoms. And of course, not all lower urinary tract symptoms are benign. Some of them are basically cancer, like for example, carcinoma in situ, or even the beginning part of the bladder carcinoma. It actually can present to you with lower urinary tract symptoms, but they are actually cancer. So now, nocturia, as we know, is an important element of lower urinary tract symptoms. There are so many people across the world are suffering from it. But do you realize that only about 57% of patients are actually not being treated properly for nocturia, even though they present with nocturia? They are being treated for overactive bladder, they are being treated for prostate disease, but they are not being further investigated to find out the actual cause behind. So from this chart, you can see that more than 50% of the patients that present to you or reported as having nocturia, they actually pass urine more than once a night. So nocturia is naturally the most common symptoms of lower urinary tract symptoms. We know that nocturia is not a single disease, it's not a single organ problem. Basically, it encompasses everything from the heart, like for example, congestive heart failure, okay, or from the kidney side, maybe diabetes insipidus, or even acute kidney injury, or even bladder outflow obstruction from the bladder side, or even the prostate, or even could be hormonal, for example, diabetes insipidus, or even the diabetes mellitus, and of course, the sleep apnea syndrome, the one that I mentioned earlier on. There are so many organs which are involved. So, not surprising, when you see all this, you will realize that nocturnal polyuria is present in majority of the patients with nocturia. From the first speaker, Dr. Shanti have already mentioned it. So a lot of us just focus on the nocturia, but we forego the fact that the patient can have a large percentage of nocturnal polyuria as well. So if the patient presents to you with nocturia and you treat them with a BPH medication, and foregoing the nocturnal polyuria, you basically miss out a part of it. So sometimes when you treat both, the patient actually give you better symptom improvement. Not forgetting the fact that nocturnal polyuria is not just in the benign prostate enlargement or those patients with the bladder outflow obstruction. Nocturnal polyuria can also be there, associated quite high an incidence in those patients with an overactive bladder as well. Now the practical rule is, if you want to treat the patient present to you with lower urinary tract symptoms, please do get the proper history, get the IPSS, find out whether the patient have some form of a prostate issues, review the medication, do a urine analysis to rule out the UTI, do the digital rectal examination so that you don't miss out the prostate cancer, apart from assessing the prostate size. Check the post-work residual because you need to know whether you're dealing with an underactive bladder or overactive bladder. And of course, uroflowmetry if it's possible. And more importantly, not the kidney function and the glucose, it's the bladder diary. I must tell you, the biggest enemy is actually not the patient, it's actually us. Physicians seldom advocate bladder diary. At least in my part of the world, in Malaysia, I can tell you that probably 90% of the doctors are not advocating the bladder diary. Bladder diary is very important because it clinches the diagnosis of nocturnal polyuria. Because if you don't do the bladder diary, you wouldn't know how much urine is the patient passing every night. And in that way, there's no way that you can differentiate between nocturnal polyuria or even nocturia. Now, most of us thought that, okay, when a patient presents to you with lower urinary tract symptoms, it has to be either BPH or overactive bladder. As I mentioned to you, there are so many examples just now. All the disease, all the symptoms can present to you something like a BPH or OAB, but in actual fact, they are not. Now, when we ask patients, we say that, okay, how many times do you pass urine at night or daytime? But very seldom we ask how much urine that you actually pass. So this is something that we have to take note as well. And of course, I mentioned to you earlier on, when we sleep, the vasopressin hormone came out. So those patients who have sleep deprivation, insomnia, restless sleep, they will not have this hormone secreted in their brain. So they will not be able to concentrate the urine properly. So they will pass urine just the same as daytime. Systemic cause, as I mentioned to you, looking at the Tango chart just now, you can see that it's multi-organ involvement. It could be congestive heart failure, it could be diabetes insipidus, it could be obstructive apnea disease and all these things. But if you're not checking through all these systems, you will actually miss the other important systemic causes. So go back to the definition. Nocturnal polyuria is not just diagnosed by counting the voids. It's also based on the proportion of 24 hours urine produced at night. And hence, you need to know the definition, which is ICS definition. For young men, more than 20% of the 24-hour urine volume. For elderly men, more than 33%. You must understand that sometimes the nocturnal polyuria can also be associated with BPH or even OAB. So in that case, you may have to treat both. Now, why is nocturnal polyuria frequently misclassified as BPH or OAB? Because as clinician, when the patient presents to you with nocturia, straight away we think that they have BPH. And for women, when they present to you with nocturia, we think that they have OAB. And for those patients who are persistently having nocturia, we don't actually bother to find out how much urine is passed at night. Because when we find out that the patient is having the nocturnal polyuria, you will go systematically one by one to see what actually went wrong with the patient. IPSS only cover the void. It doesn't cover the urine volume. A lot of people do not know that. And of course, some people think that if I were to give the prostate medication to improve the void, the nocturia will also get better. Well, if the patient has nocturnal polyuria, the patient's problem will still persist. So, treating BPH alone may not solve the nocturia when the nocturnal polyuria is the driver. Likewise, there are some patients who combine the overactive bladder medication together with the bladder outflow obstruction. Basically, they give anticholinergic combined together with the prostate medication such as alpha blocker. But sometimes you see that there's no improvement at all. In that case, please do think about the associated nocturnal polyuria, because you can see a very high percentage of them are actually associated with it. So, if patients actually present to you with BPH, if you were to treat them with desmopressin, having probed further into the history, knowing that he actually suffered from associated nocturnal polyuria, you will make him feel much better. Likewise, for those patients who have OAB, also find out whether the patient have nocturnal polyuria, because you can see up to about 60% of them are having nocturnal polyuria. So treat them with desmopressin. A simple diagnostic checklist will be, first of all, find out whether the patient is truly waking to void. Is nocturnal urine volume increased? Are the night voids large or small? Is there any obstruction at all, suggestive of benign prostate obstruction or even the urinary stricture or even urinary retention? Find out what medications the patients are on. Very importantly, emphasize on the bladder diary. Now, if you can't do 3 days, at least 1 or 2 days. Now, is 24-hour urine volume normal or globally increased? Because we must understand the nocturia actually have 3 elements. The first one is nocturnal polyuria, the second one is global polyuria, and the third one is bladder storage problems. So you have to find out the 24 hours urine volume, not just the night one. Is there any urgency suggestive of OAB? And are there any systematic causes such as edema, obstructive, sleep apnea, heart disease, heart failure, kidney disease, kidney failure? Is the patient having a normal sodium? Because if the patient have low sodium, you may not really want to start the patient with desmopressin. So the treatment should really match the mechanism. If the patient have increased, fluid intake at night, maybe ask them to hold off, don't drink too much, don't drink the caffeinated or carbonated product. If the patient have this leg edema because of congestive heart failure or even the kidney failure, then you ask them, instead of waiting until late night when they sleep, maybe during afternoon time, elevate their leg so that there's a fluid redistribution so that they won't end up passing urine so many times at night. Sleep apnea. Go further into finding out whether the patient needs CPAP or not. Treat the heart failure, treat the renal disease. And if genuinely this is a true nocturnal polyuria, give desmopressin. And if the patient have OAB or even prostate enlargement, treat accordingly. So the take-home message is that confirm whether this is a nocturnal polyuria. Okay, confirm it with the bladder diary, very important. Exclude other things such as global polyuria, OAB, BPH. Start the conservative treatment first. Maybe you can ask the patient to avoid drinking too much at night, avoid drinking all the caffeinated, carbonated product, manage the edema. Instead of lying down only at night, maybe in the afternoon, lie down with the leg up so that there's an equal distribution of fluid into the body. Then they won't end up passing urine so many times at night. Treat the systemic causes. If persistent, confirmed nocturnal polyuria, give the patient desmopressin. Check the sodium before that, very important, and repeat the diary to document the response. So the key takeaway is nocturia is most commonly driven by nocturnal polyuria, not just the bladder. Nocturnal polyuria is common and yet frequently underdiagnosed, underassessed, undertreated. Standard lower urinary tract symptoms, treatment alone are insufficient when the nocturnal polyuria is the driver. Desmopressin is the target match therapy for nocturnal polyuria, and it can be given together for those patients who suffer from BPH or OAB because majority of them were found to have a strong association with nocturnal polyuria. For that, I end my presentation. Thank you.
Dr. Wallen, for your excellent talk. Yeah. And, I truly thank you for taking us to a practical point, that many of us might be overlooked, in our clinical practices. Yeah. And I particularly like your line, Warren, if you don't measure it, you won't diagnose it. Yeah. Thank you so much for reminding us to the basic, taking medical history, taking care of the patient. Thank you. All right, so we will, move into the MDT panel discussion, which I suspect is really practical heart of tonight's program. Together, we will explore several real-world cases highlighting the multidisciplinary pitfalls surrounding the nocturnal polyuria. And once again, the audience is online. Please do continue submitting the questions in the chat box as we go along, because at the end of each case presentation, we will spare around 5 minutes for the Q&A. Yeah. So I'm now delighted to welcome back Associate Professor Le Din Khan. Yeah, we will learn from him for the first case, and he will present, the case 68 years old gentleman treated with presumed BPH with an alpha blocker, flow improved slightly, but nocturia still persisted. Over to you, Professor Khan.
So I continued with another topic. I would like to present a clinical case regarding nocturia in patient with BPH. Male patient, 65 years old, came to us for examination because of nocturia. Regarding the patient's medical history, patients experienced dysphoria and nocturia about 5 to 6 times at night, approximately 1 year ago. And he was examined at Ho Chi Minh hospital in Ho Chi Minh City. In that time, he lived in Ho Chi Minh City, about more than 100 kilometers from our city. And ultrasound in that time showed that the prostatic volume about 49 milliliter. And we can see here the prostate is a little bit big. PSA was within in the normal range. And the patient was diagnosed with BPH and treated with alpha blocker medication monthly. And we see here the HANA gas. This is the tamlozine hydrochloric from Astra company. And the patient used this medicament until he came to us 1 month ago. And over 1 month ago, the patient returned to his town near our city, about 200 kilometers, and came for examination in to us because of nocturia. And we examined the patient and found that the patient had nocturia 5 to 6 times at night, urination time prolonged, IPSS 12, QOL, OL4, and ultrasound showed that prostate volume of 55 milliliters, blood sodium within normal limit. And uroflowmetry showed that we can see here the Qmas is normal, but the total time duration is long, 45.7 seconds. And at the end of the duration, the patient some strengthening. With uroflowmetry, we know that we believe that the patient beside the BPH, maybe the patient has another condition related to nocturia, and residual volume, urine volume at that time 36 milliliter. What's appropriate diagnosis for this patient? Benign BPH or nocturia only, or benign processes hyperplasia combined with the nocturia. In this patient, we think that the diagnosis of BPH and nocturia in this patient is clear. However, nocturia can be a symptom of BPH or a manifestation of another condition. As I said, in this patient, we have not yet clearly identified the cause of nocturia. So we have a diagnosis co-occurring BPH and nocturia. And what is the cause of nocturia in this patient? If the patient have nocturia polyuria or not. And until now, we have not yet determined this because of the patient have not completed the bladder diary. And what was the appropriate treatment option? We gave 2 options. Option 1, only mirroring. If we diagnose only nocturia, we choose option 1. But in the patient, we choose this BPH combined with the nocturia, and we choose option 2. And we gave the patient Satran monthly, 30 days, and mirroring only 20 days. And after 1 month, some days ago, the patient come to us for controlling, and nighttime urination decreased to 1 to 2 times per night, IPSS 8, QN 1, and uroflowmetry. We can see here the Qmas is not is relative normal, but the total time urination is better. Now only 30 32. Before is more than 40. But at the end of the duration, the patient have one straining, and we believe that the patient will also have another condition related to nocturia, and for this patient, does the patient have a nocturnal polyuria? And what the role of bladder diary in diagnosing nocturia or nocturnal polyuria? The patient experienced nocturia, however, we could not confirm whether nocturnal polyuria because no bladder diary. The bladder diary plays an important role in diagnosis of nocturia, especially nocturnal polyuria. However, because the patient was unable to have bladder diary diagnosis difficulty, but we believe that the prescribing medication should only be given when there is an accurate diagnosis. Although treatment with minerin has been effective and in clinical practice, many of our patients treated with the minerin have shown good result without bladder diary and a more accurate diagnosis nocturnal polyuria is necessary. However, we currently face obstacle in Vietnam, as I have presented in my report earlier. We hope that in future, with the availability of better supporting solution, the diagnosis will be similar, and we will continue to follow the patient, and maybe the patient have a we found that another condition related to nocturia. Thank you so much for your attention.
Thank you, Dr. Khan. Okay, I think the case that you present is really beautiful, and actually, I think this case we have a lot of things to discuss if we have more time. May I have you a question from the online? They want to ask you about how many days do you suggest for patient to do the bladder diary? And in your opinion, actually, how many days that you think is proper for bladder diary in your clinic, in your field?
Normally, we bladder diary in our clinic is for 3 or 4 days. But as I represent, this is not all patient because we have some problem because the patient not cooperate with us to complete the bladder diary, and this is the problem in diagnosis nocturnal polyuria in our clinic.
Okay, because in your talk about the bladder diary in Vietnam that I have listened, I think I understand about the problem in Vietnam, and so that means for you need 2 or 3 to 4 days of the bladder diary, right? And like in this case that you present, I understand about some limitation in the Vietnam patient. About so I have a question about when you don't know exactly in the bladder diary for your patient, and when you try to start treatment, how often that you have the hyponatremia in your patient?
This is the problem. The rate of hyponatremia is until now in literature is very low, and in Vietnam we have some conference about this, and until now we have one case in Hanoi, but long time ago, And you see in our patient I presented, we give only 20 days at a not 30 days, because that is only in my experience, our experience, because if the hyponatremia normally occur in after 1 week, and then if the patient, we cannot follow the patient, we cannot know whether the patient have hyponatremia or not, and we use mirroring only 20 days. If the patient have the patient have a hyponatremia, the one without the medication, the hyponatremia may be passed, and then we after 1 month the patient come to us. I think in that time all the natrium in the blood is normal, and we can continue to treatment the patient. And that is only in our experience in my clinic. Yeah.
Okay, Professor Kant, and thank you so much. Actually, we still have 2 minutes for your case. Okay, no more question from the on. All right. Okay.
No.
So may is no more question. May I have for me one question? In your experience, like in this case, you don't have any bladder diarrhea, and your patient still have the nocturia 4 to 5 times that you show me. Before you try to start the mini rinse or desmopressin, do you believe or you advise about the behavioral treatment before bed? I ask about this question because most of the Thai people, they always think drinking too much before bed is always like a prevent stroke, something like that. What do you think about that?
I think if we diagnose the patient before the treatment, we must give advice for the patient. And BPH, the first we must advise the patient not drink so much in the night. Normally, I give the advice that from 5 o'clock p.m. the patient drink not so much. That is very important, because if not, the patient usually drink so much water in the night. It's not good. We must combine the treatment and advise the patient.
Yes, totally agree, Professor Kant. Thank you so much for your excellent talk and also a beautiful case to discuss today.
Yeah, thanks so much, Prof. And then we're moving to the second case to highlight about the most important consequences, with the elderly female, recurrent nocturnal falls and poor sleep, and urgency overnight as well. So let me introduce you with the second speaker, Professor Wong Jin Bae. Professor Bae is from Seoul St. Mary Hospital, Catholic University of Korea, and specializes in sexual dysfunction, prostate disease, and overactive bladder. He's currently serves as a director of the Korean Continent Society and is actively involved in translational research, medical innovation related to functional urology. Please join me in welcoming Professor Wong Jin Bae. Please, Professor Bae.
Hello, I'm Wong Jin Bae from Catholic University of Korea. Yeah, nice to meet you too all. And I present about the following patients for the elderly patients. So I'll show you a representative case, a 72-year-old female patient presented with urgency, frequency, and nocturia. She was diagnosed OAB with some tests. She didn't void some urine on fluorometry, uroflowmetry, and checked the frequency urination and nocturia on voiding diary. and I prescribed the mirabegron. While her daytime urgency and frequency improved, her nocturia persisted, so she experienced 3 falls over the next 6 months, all occurring between 2 and 5 a.m. This case highlights that improving daytime OAB symptoms does not eliminate the risk of nocturnal falls. Why is nocturia such a potent risk factor? According to the data, there is a clear dose-response relationship. While 1 or 2 boys per night already increased the adjusted risk of falling by 41%, the risk peaks at the odds ratio of 2.1 for patients voiding 4 times per night. This significant increase demonstrates that every additional trip to the bathroom at night heightens the danger of fall accident. The situation becomes more precocious as patient age. This data shows that an 80-year-old patient have 2 or more boys per night brings the annual fall risk to nearly 45%. This is a significant jump compared to those with fewer boys. Furthermore, the relative risk of fall-related fracture is increased. Why does nocturia lead to such a dramatic increase in mortality? It isn't just about the fall itself. It's about 2 pathways that compromise the patient's survival. First, it is the cardiovascular pathway. We know that healthy sleep involves the natural nighttime blood pressure dipping. However, frequent awakenings disrupt this cycle, leading to sustained sympathetic nervous system activity. Second, we have the accident pathway. The chronic sleep fragmentation caused by nocturia leads to severe daytime fatigue and nighttime grogginess. This leads to the falls and fractures. Recent data shows that adhering the low-risk sleep patterns can add 4.7 years to the life expectancy of men and 2.4 years for women. Since nocturia is the most common cause of sleep disruption in the elderly, our urological intervention are directly linked to extending our patient lives. Finally, nocturia is associated with a higher risk of falls and fractures, increasing mortality risk in older patients. So these all data mean that nocturia cause impaired sleep or accidents, and it makes overall increased risk of death. So we have to make integrated intervention, especially in the urological domain. We have to use OAB medication to use behavioral modification and a targeted therapy like desmopressin to specially reduce nocturnal urine volume. So finally, in conclusion, managing the falling patient requires more than just standard treatment. We must adapt an integrated approach that specially targets nocturia, sleep patterns, and life cycle. Thank you for your attention.
Yeah, hello. Okay, thank you so much. Let me check on the online. No more question from online. Oh, okay. A moment.
Thank you very much, Professor. I have 2 questions would like to ask
Okay.
you. Okay. The first one is, have you aware about the non-dipping hypertension in patients? Because most of the time, elderly patients, they carry their hypertension, and sometimes when they go to see the internal medicine at the clinic, usually it is in the morning, but sometimes the medicine cannot cover the level of the blood pressure all along the night. So have you aware about the non-dipping hypertension that would be the cause of the nocturnal polyuria? And if so, how can you diagnose that?
You comment about the hypertension?
The non-dipping hypertension, that the high blood pressure level at night.
Well, I didn't check the blood pressure about that. Actually, there's no any side effect about the blood pressure changement about after medication of the desmopressin. But sometimes I cautiously check the hyponatremia, just warning.
Okay, thank you. And for the second question, as now there are, I saw your example patients that they have quite an advanced age, and this age may be carry an increasing in the risk of hyponatremia. So I would like to ask you that to prescribe the desmopressin in elderly people, when you feel safe and confident to prescribe desmopressin to them, is, for example, like sometimes the older people, they stay home alone, some kind like that. Would you prescribe the desmopressin to this type of patient?
Sorry, I can understand about your question.
Okay, when you feel safe to prescribe the desmopressin to elderly patient,
Yeah,
because sometimes they stay home alone.
But I was cautiously checked the sodium blood level, and I cautiously checked the subjective or objective symptom about the hyponatremia. But mostly the patient with elderly people, if the patient have no any symptom about the hyponatremia and the symptom is relieved, I prescribe the medication for a long time.
Okay, thank you, Dr. Wong Jinbae. And in your point, I think it's very important about the elderly have wake up during the night and then got falling and fracture. Okay, I think it's a very important point. And for my colleague about she concern elderly patients stay around in their house and falling after get any problem from side effect whether by the vasopressin mineral or something. But I think is we can look in two sides, because actually if the patient have the nocturnal polyuria and stay alone, have to wake up very often, go to the toilet, so we get the risk of the falling also. Okay.
Yes, I understand it.
Okay, thank you so much,
Can
Doctor.
I have a question? Can I have a question?
Okay, sure.
Yeah. In my clinical case, I talk about the patient, the male patient with the BPH combined nocturia, but I think in the female, the cause of nocturia is very different and complicated to diagnose. I want to know. I want to ask a question to ask you. If the female patient come to you and with nocturia and bladder diary, of course we must advise the patient complete. I think it's very important. And you prefer to use another medication or mineral first?
Yes, actually in Korea, we have two kinds of desmopressin. One is the desmopressin oral pills. Actually, it is approved by nocturnal polyuria, but sublingual desmopressin is approved by the nocturnal polyuria and just nocturia. So if the patient have the decreased nocturnal volume, then I prescribe the antimuscarinics of the beta-3 agonist, but if there is no effective, but then I prescribe the sublingual desmopressin again. because it is also effective for the decreased nocturnal urine volume.
Okay, and then when you use mirroring, how long the patient can use mirroring?
I prescribed firstly 1 month of medication and checking the sodium blood level, and if there is no abnormal level of sodium and there is no any abnormal findings, and I prescribed more.
Do you have any patient with hyponatremia because of the mirroring?
Yeah, actually, but I have some patients, but I have the cutoff line of the 135 and the lower patient, even though the lower sodium patient, but they have no any subjective symptoms. I cautiously prescribe the medication more.
Oh, thank you so much.
All right, thank you so much for the fruitful discussion. Now case 2 highlighted physical consequences of nocturia. So our final case, perhaps we touch it more a little bit on the cognitive and behavioral side effect. Let me introduce the final speaker, Assistant Professor Walirat Sovet Sutipan. She's the faculty member of the Division of Urology at Thammasat University Hospital and the director of Neurogenic Bladder Center of Excellence in her institute. She specializes in functional urology, neurogenic bladder, and geriatric continence care with an international training experience in the United States. Please join me in welcoming Associate Professor Vadirat, please.
Good evening, everyone. Thank you very much for having me here to join the cast. This case is quite like I think it's like a very high prevalence and high incidence as we can see this type of patient at the clinic. Okay, let's start with the patient demographic. She's a 40 years old female. She worked for the government officer and she had a significant urgency and urge incontinence. No pain, no hematuria, no dysuria. But she complained that she often coexisting with the severe insomnia and fatigue. And of course, she have a nocturia for 4 to 5 times a night for 4 to 5 months. But during the day, she was usually 3 to 4 times. So at the clinic, the first doctor is a general urology. General urologist, he did a physical examination. She has a high BMI at 28. That means she has an obese people. The blood pressure is normal. She no full bladder. The ultrasound shows normal, but her bladder can hold the volume of the urine up to 800 mils. And no post-vagal urine. The urine analysis is normal, and she said that she have a rapid weight gain after the contraceptive implantation. And for the first bladder diary data, okay, you can see that the first time she have a nocturnal polyuria index for over than 33%. And at the first time, she was advised to do the lifestyle modification and start the mirabegron 50 milligrams to treat her urgency. And then at that time, the nocturia decreased to 2 to 3 times, improved urgency, no incontinence. But she still border from the nocturia. So the first doctor started desmopressin for the oral form for the start with the half of the tablet, but her symptoms did not improve. Then they increased the dose into 1 tablet per night. And they follow the level of the sodium is to be normal, is in the level of the 137. And so at that time, the first urologist, he suspect about the obstructive sleep apnea by her obesity. So at in the meantime, he sent to see the sleep doctor and to do the polysomnogram. And yes, we found that she have a moderate obstructive sleep apnea with obstructive airway, and she have such oxygen saturation nadir justly 87%. And at that time, they tried to fill her with the APAP, and her symptoms improve. So for this patient, you can see that otherwise than the urology condition, she also have a sleep problem, that she have an obstructive sleep apnea that's improved by the APAP. And also she complained that she have an insomnia problem that not caused only from the nocturia or from the other problems, not only from the overactive bladder, but we found that she have a major depressive disorder. So we sent her to see the psychologist, and the psychologist started the medicine to her and to cure about the sleep architecture for her, and her symptoms improve about insomnia. And the nutrition, you cannot solve the problem for the obstructive sleep apnea and the nocturnal polyuria by only helping her in other ways, but you have to help her to improve her nutrition also. So we consult the nutritionist to help her about the metabolic focus. So they start the semaglutide for her and adjust her diet and advise her for the exercise. And after adjust for the other medical conditions, her sleep bothersome from the nocturia reduced into 4 from 5 times. And she still have a daytime sleepiness, fatigue, and she still have to wake up at night to pass urine. And after have a nocturia, she cannot back to sleep again. And she complained that she have a decreased work production. And so at this time, the first urologist consult to the functional urology clinic. And because the patients feel that for the oral form, 1 tablet and mirabegron, 1 tablet is not work for her, so she stopped taking every medicine. And when she come to see me, I do the lab workup for more, because I suspect by her clinically and her physical examination, I suspect about the diabetes. But the blood sugar is normal, and the creatinine just only 0.6, and BUN is normal. So I do the bladder diary again, and I advise her that she must complete the bladder diary in the true information, because this one is important. If she wants to recover from the nocturia, she have to collaboration with my treatment and my way. Okay, so she intake the fluid about 3 liters per day. That's quite high volume. She wore at during the day for 4 to 5 times. The average capacity is about 350. Max she can do at 500. She has nocturia for 3 times, average for 300 to 450 for each time, and max at 550 also. For the nocturnal volume, we calculate that is 1,300. That means nocturnal polyuria, because the nocturnal polyuria index is still over than 33%. And note that she have habit to fluid intake about 500 to 1 liter per before sleep. So that's one, what should we do? Okay, so first, I suggest her to fluid restriction. She needs to stop fluid intake at least 2 to 3 hours before sleep. This one she needs to do. And she needs to walk at least 30 minutes before bedtime, before sleep, because she needs to empty her bladder as much as she can. And she needs to avoid the stimulant control. She needs to zero caffeine afternoon, because we know that the caffeine and alcohol can promote diuresis for at least 6 to 8 hours after intake. And we focus on dryness in evening. And we change the type of the desmopressin, because the oral form may be not suit for her. So we change to the milk form, and we restart the mirabegron again. to treat her overactive bladder. Okay, for this one, at the first time, they start with the one tablet for the oral form, and her nocturia didn't improve. So we switched to the male form for the one tablet with the lifestyle modification. Her nocturia improved to just only 1 to 2 times per night. But she still have a problem about the insomnia and daytime weakness. So I titrate the male form into 1.5 tablet. And now she she said that at the first time for the first 2 weeks, everything is okay. But now her symptoms is worsened. She back to have a nocturia for 2 times with bothersome symptoms. And I also regular sodium monitoring and the level is normal. So I recommend her to do the bladder diary again because I want to check so what happening. Because at the first 2 weeks, everything goes well for what happened. So for the left hand side is 1 tablet for the male form, and the right hand side is 1.5 tablet. You can see that after I changed to the 1.5 tablet to 90 microgram, the nocturnal porphyria index decreased to just only 28%. So she solved from the nocturnal polyuria problems. But she started to have a decrease in the nocturnal bladder capacity. So you can see that at night, her bladder capacity reduced into just only 150 to 250. So I suspect that maybe her bladder capacity that reduced maybe from the overactive bladder that not complete resolve or something like that can occur in female people. So I try to add the imidafenacin for 1 tablet in the evening. And and after she came back to follow up, her BMI reduced day by day. And as day by day that her BMI reduced, her weight reduced, her sleep quality improved, and her airway improved, and also her nocturnal polyuria improved. And at this time, nowadays she have nocturia just only 0 to 1 times. It depends on her drinking in the late evening. And her sodium is still stability, can maintain in the normal level. Her sleep restore architecture with the APAP and the medicine from the psychiatrist. And her mental health improved a lot. She have improved mood, and she can do work that more productivity. And now the voiding diary show normalize the nocturnal porphyria index. So the conclusion for my case, the nocturia in the middle-aged patients, not only men, but also the women, is rarely just a bladder problem. First one, you need to look for the medical condition like a metabolic disease, like obesity, hypertension, systemic inflammation, and other problems. The second one is a functional bladder capacity that we need to look for. And also the most important is the nocturnal polyuria that's caused from maybe the obstructive sleep apnea or maybe from the lack of the desmopressin. So integrate management is the key to treat the nocturia problem. Thank you.
Well, thank you so much. I think it's to be a really challenged cases because actually in this case, she have a lot of things: obesity, obstructive sleep apnea, insomnia, OAB, and then nocturnal polyuria. Wow, okay. So actually we have a question. We all lied. Body mass index of the patient. Can the patient respond to higher doses of the vasopressin? Okay. The question is about if the patient have a high BMI. What do you think about the doses of the vasopressin?
I have no information about this one. It's quite challenging question. Maybe I think it can be in 2 ways. The first one, yes, maybe she need to take more higher dose because usually we can see the female patients they have a higher risk for the hyponatremia. But for this patient, maybe obesity. But another thing that we need to concern that if the patient have obesity, because the fat can cause the drug distribution and can cause more higher level of the complication. So what do you think, Dr. Sontidet?
Okay, before I give some opinion of mine, I want to let the Dr. Lee Din Kwan from Vietnam and also Dr. Wong Jin Bear. Maybe if you want to share something, you can share. It's okay. For me, in my opinion, sometimes it's not related with the body mass index, because actually I have two cases, women, not just slim women, but quite elderly. I try to increase to be the minerin tablet, 2 tablets per night, because the 1 tablet doesn't work enough. The better diary is still showed nocturnal polyuria, and whenever I try to increase doses to be 2 tablets before bed, it's work for them. Actually, both of these patients, it's just a normal body mass index. And about this question, in your case, I don't know why, because you start with the minerin tablet, but it look like didn't work anymore. But when you try to change to be the sublingual melt tab, it's work. I don't know what about that.
From the data and from the research information, the male form has higher bioavailability and it can cause more effective to the treatment in the patients, both the effectiveness and decrease the complication, because they can work more properly than the oral form.
Okay, thank you so much. Okay, a question from on site.
Dr. Kiri from Bhumipol Adulyadej Royal Thai Air Force Hospital. I have a question for Dr. Wadilat. I have experienced the same kind of patient, but she is under Social Security reimbursement program and Universal Healthcare program. I think we all know that minerin is not reimbursed outside of the government officials reimbursement program. So if this patient cannot reimburse this medication, what would you do? And the other question is that is there any chance that this minerin can be included in the other reimbursement program in the future?
Okay, for the first one, let's check with the price. Maybe the oral form is quite cheaper than the male form, but we need to first, until now, if we can reimburse for the patients, we need to talk to them. Sometimes the price of the medicine is worth for the quality of life that they can improve, but in the case that they cannot afford anything, so we need to talk to the foreign pharmaceutical company to work for this one to help patients. But actually, in my hospital, the UC can reimburse for the oral form. Mm-hmm.
We try our best.
Okay, one more question from to Dr. Kim. We need to also focus on others. Okay, the question to the Professor Kim, will we need to focus with other sleep parameters, express, or how can we measure quality of life? Actually, I'm not sure about the question.
Okay, to Professor Kim, we have a question from the other side that do you need to focus to other sleep parameter, not only than the not only the first uninterrupted sleep, and can you measure quality of the sleep? Maybe in some area they cannot send patient to do the polysomnogram. How could you examine the problem of the sleep of that patient?
May you, the Professor Kim, you may turn on the microphone, please.
Okay. Can you hear?
Okay, now
Can you hear me right now?
sure, I hear you now.
Okay, so you're asking that if there's some other parameters to evaluate the sleep disturbance of the patient, or did I get it right?
Yes, I think correct. So what do you think about that?
Oh no, actually, well, I don't have some other tools to actually in my clinic I don't actually use any tools for sleep disturbance. I just ask the patient how he or she feels about her or his present status. So, there's tools to evaluate the sleep disturbance. I just usually seek for help for the psychiatrist, for the psychiatrist. Just wait a second. So I send them to the experts for the sleep disturbance, the sleep clinics. So actually, I don't actually do the evaluation for the sleep disturbance presently. So I just ask them how many times they wake up in the night, and that's the only tool that I use in my clinics to manage nocturia. Right.
Okay, Professor Kim. I think about the nocturia, like the Dr. Warren talk in that slide. I think several sort of the problem to be a cause of the nocturia. So not sometimes not a lot of things to be a cause of the nocturia. So quite hard to answer about that question. And now we have a question to Dr. Warren. Can you do combination therapy with desmopressin, alpha blocker, beta T agonist, or anti-muscarinic with the desmopressin? Actually, this question is about can we combine everything for the lower urinary tract function for your patient? Dr. Warren, what do you think about that?
Well, truth be told is that most of the time, I seldom actually give a combination of all these three. But then, yes, OAB with the desmopressin or BPH with the desmopressin, yes. But if you were to ask me about a combination of these three, I actually seldom. Now, the truth is that because a lot of us actually need to find out there's an entity called underactive bladder. Like for the last presentation just now, she was actually under some form of an anti-psychiatry medication or maybe some form of a tranquilizer. Now, a lot of us do not realize that, some of the sleeping pills plus the tranquilizer itself also can cause bladder relaxation. So that become a little bit of a, that confounding factor to decide what you want to do for the patient. So I think that for me, I would really want to find out what exactly is the patient having. Because unless the patient have a neurogenic bladder, for example, like spinal cord injury or something that can present with overactive bladder at the same time with an underactive bladder entity in there, otherwise, I actually will be, doing all these things very cautiously. I think nocturnal polyuria, yes, is actually multifactorial, but at the same time, sometimes when we treat patients, like for example, you talk about the sleep insomnia causing the nocturnal polyuria. So you want to give the medication to treat the insomnia. But at the same time, the medication sometimes can also cause bladder relaxation, just like the tranquilizer. So you got to really play it very, very safely. That's my opinion.
Okay, thank you, Professor Warren. And again, we have a question to you, Professor Warren. Any specific career patient? Okay, the question is about if we don't have the better diary because of any reason, the patient could not respond or could not do any better diary for you. What will you to clarify and treatment about the nocturnal polyuria in your case, in your patient?
I think number one, I need to find out whether the patient, even though he cannot or she cannot, maybe there's a caretaker that can actually do it for him or her. So that's number one. Number two, I would really advise the patient to actually do it, during the weekends, especially during the holidays or the public holidays, so that they are not actually entangled with some form of a work commitments. I think if really they cannot, then I have to go all around it, starting from maybe the Euroflow or the post-op residual, and after that, find out in detail about the history of the patient. Also check and see what sort of medications that the patient is on. And of course, I do actually do a physical examination. That actually goes back to the question just now, when the women present to us with a nocturia. Now, I think a lot of us do not actually examine the external genitalia of the woman, but you must understand that men will have this prostate enlargement. Women also, especially the postmenopausal one, will have a meatus and also the urethral stricture. That can also cause some form of an overactive bladder, or even the bladder dysfunction. So I think that can present to you with a nocturia. So I think that actually has to be emphasized upon as well. Talking about the Euroflow, also I can also see that a lot of patients, when they actually go for a Euroflow study, they were being asked to drink a lot of water. You must understand that if you were to overdrink, then what is going to come out from the Euroflow results will be, number one, it takes a long time to empty the bladder. Number two, they have to strain a lot to empty the bladder. So over distension of the bladder can also result in reflex contraction or spasm of the pelvic floor muscle. So sometimes can give you a wrong results. That's why when you do the Euroflow, when you ask the patient to drink too much water, you can see that towards the end, the patient still got to strain and strain and strain, because there's a reflex, pelvic floor muscle spasm. I think this is also has to be taken into consideration. So basically, this is just an example that if I do not have avoiding diarrhea, how do I go about doing it? So I'll just go all around from physical examination to the Euroflow to check the medication and to ask in detail history.
Okay, thank you. And now, one more question. We are online. The question is, I think it's about the how can we clarify about the nocturnal polyuria from the OAB or the small bladder capacity in elderly patient. I'm not sure about this question, because if I answer in this question, I think the bladder diary is very important to separate, to clarify about this. But I think maybe this question similar to the question before that Dr. Warren have already answered about this question, because if we don't have bladder diary, how can we clarify nocturnal polyuria from the OAB patient? Who think about this? Okay.
Can I answer
please.
this question? Okay, all right. Okay, so number one, you must understand that overactive bladder, there's a difference between overactive bladder and also overdrinking and also nocturnal polyuria. So for those patients who overdrink, they actually pass urine a large amount every single time. For those patients who actually have an overactive bladder, they go many times, but at the same time, they pass very little urine. Multiple times, increased frequency, but very little urine each time. That's how you differentiate between the two. But you must understand another entity about this nocturnal polyuria is that a lot of us think that, okay, nocturnal polyuria, the patient would have actually gone many, many times to pass urine because it's actually increased urine output at night. The truth is that if you at night, and if the volume is actually more than 33% in elderly and more than 20% in young, it's still a nocturnal polyuria. It is not necessarily a frequency, it's the volume.
Thank you, Professor Warren. It looks like Professor Kim, you leave your hand up. Do you want to answer in this
No,
question also? Okay,
yeah,
please.
yeah, I'm Dr. Bear. Yeah, sorry too late. Actually, I asked the patient about the nocturnal urine volume comparing with the daytime. So I asked the patients, how about the nocturia? I mean, the nocturnal volume is the lower than the daytime urine volume. So I think it's the kinds of the functional capacity. So if the urine volume is lower than the daytime urine, then I prescribe the desmopressin, even though there is no any documents in voiding diary.
Thank you so much. Thank you so much to all speakers, audiences, for such an insightful discussion this evening. It's such a pity we have got limited time. Yeah. And I think tonight's program, I think we have highlighted one very important message, that nocturnal porphyria is not just a simple bladder symptoms. It is a multidisciplinary condition with very real consequences for sleep, for cognition, and healthy aging across our region. Yeah, and I think we have got the solution for patient, right? In terms of meticulously caring, history, physical examination, and prompt diagnosis. And also we have got the drug to treat the patient as well. Yeah. Perhaps I would like to invite Dr. Sontidet, the president of Thai Continent Society, for the closing remarks.
Okay. I think the time is running very fast. It's not look like a 2 hour that we have a lot of discuss all together. It's unbelievable. Okay. And for me, the first and foremost, Thai Continent Society, with my deepest appreciation, goes to the all speaker and panelists for sharing the knowledge, experience. I think we have to enrich discussion and inspiration very much today. I think it like to be the maybe the I could not the first time, but we have several times. We have the international talking discussion. We all like this, but I hope the meeting today will be the good opportunity to build stronger connection and future collaboration together again and again. And although the special thanks for our sponsor, foreign company, to organize very smoothly and successfully, but sometimes there's a little bit problem from the internet, from different country. It's okay. So for the Thai Continent Society, we would say looking forward to have a joining all together again and again, anytime, anywhere, and hope to have a good collaboration and to be a good friends forever. Thank you so much.